This slide reminds me to say something that I feel quite strongly about because I am one of the leaders in the field of chronic pain. One of the big problems we have in the chronic pain field is we simply don't have really effective drugs. Compared to other diseases or other medical conditions where there really have been fairly dramatic advances in our last 20, 30 years. You can tell that I'm old. I was trained as an internist in the late 70s or in the late 80s. And so I vividly remember that the drugs that we had available to treat high blood pressure, high cholesterol, coronary artery disease, and things like that were actually only marginally effective in the 80s. We had a couple classes of drugs. A lot of people with those conditions we weren't able to manage very well. But in all of those fields, there have been fairly dramatic advances in drug therapy, Lipitor to treat high cholesterol, a number of new diabetic drugs that are aimed at different elements of diabetes, a whole host of new drugs to treat high blood pressure. But again, those advances in those fields in fundamentally better drugs led to fundamental improvements in our ability to treat those illnesses. There have not been any comparable advances in the pain field. And in fact, a lot of the drugs that we're using in the pain field are derivatives of drugs that have been around for centuries. Opioids have been around for centuries. Cannabinoids, I'll talk a little bit about medical marijuana and cannabis for use in pain, has been around for centuries. Even the non-steroidal anti-inflammatory drugs have been around for a long time and are all derivatives of aspirin, which came from willow bark a long time ago. So a lot of the drugs that we're using are really old drugs that are only marginally effective and only work in some of the people that we give them to. And thus it becomes even more important for people with chronic pain to embrace the use of these non-drug therapies because if the drugs alone aren't effective enough to manage the pain, then you're going to have to move over to some of these non-drug therapies. And again, I'll talk a lot about how the best management of people with chronic pain is incorporating the right drugs and procedures for the right kind of pain, but all people with chronic pain, all patients that have chronic pain should be using these non-drug, non-pharmacologic approaches. They really should be the foundation or the bedrock of what you're using to treat your chronic pain, and then add the drugs and add the procedures where they can be helpful. But don't think of the drugs or the procedures as being the do-all or end-all, because that will be a pretty frustrating path for you as a chronic pain patient if you're just waiting for that next drug that the next doctor is going to prescribe for you that is magically going to take your pain away. It doesn't happen. If it did, I wouldn't need to be giving lectures every 2 weeks, and we wouldn't have to be doing so much work into the fundamental mechanisms of pain so that we can develop new drugs that are attacking those mechanisms. The other thing that I always remember when I show this slide is I'm going to talk about medical marijuana briefly. I went to the University of Michigan in the 1970s, and I did smoke pot recreationally in the 1970s. I'll talk a lot about the difference between recreational use of marijuana, which is what I was doing in the 1970s because I was trying to get high, and medicinal use of marijuana, where we're actually trying to not have people get high. The goal, if someone is using marijuana medicinally, is to find a dose that controls their pain, that doesn't make them high. But having said that, I actually think it's useful for me to at least acknowledge that on my conflict slide, as a theoretically someone that didn't go to the University of Michigan and wasn't this bleeding liberal that I am, might have a different view of medical marijuana.